Okay, thank you, COLDA, for giving me this chance to present my abstract on this virtual conference platform, and I feel honored. So this poster is on assessment of non-invasive markers of liver fibrosis in patients with hepatitis C virus in Ethiopia. So I have nothing to disclose. My outline looks like I'll go with the background. I'll try to discuss the methods that we have used, and then I'll discuss with the results, then discussion and conclusion and final recommendation based on the study. So background, we have seen that nearly 71 million people had global hepatitis C virus infections. There are some recent updates, but we have seen that around 10 to 15 million of these people actually live in sub-Saharan Africa. And actually 20 of the countries that have the global burden of the hepatitis C virus also live in the low and middle income countries. And despite this number, less than 2% are identified, diagnosed, and on treatment. So hepatitis C virus but we have seen that hepatitis C virus treatment has an SVR rate of more than 95%, and with an effective treatment of 2 to 3 weeks, yet patients are not identified and treated. And patients who are on DAA, even though they have SVR, they are likely to have to progress to decompensation and cancer. And there is a need of follow-up of their liver status. If you start them when they have early cirrhosis or cirrhosis, it's a progressive disease, so we need to have a follow-up. So we need non-invasive tests to identify the patients who have cirrhosis, even though they have an SVR. So it's a progressive disease, and cancer has been reported mainly also in those patients who have SVR. So the use of non-invasive tests for assessment of a liver fibrosis and cirrhosis will be very important in resource-limited settings. With the liver biopsy it's not feasible. Transient elastography has also been shown that it's expensive and it's not usually affordable, and it's not available in many parts of African or sub-Saharan Africa and other low and middle income countries. And the other important thing also, we have, if we screen patients with hepatitis C virus, we also need to prioritize those patients who need early treatment, like patients who have cirrhosis, so that they will have early treatment, and also patients with cirrhosis who have been on treatment also needs follow-up even after completion of the treatment. So to prioritize patients to start treatment and also for follow-up and for monitoring purposes, we need to have an non-invasive test that's not like a liver biopsy or a transient elastography. So we want to assess actually to validate the known non-invasive markers which are based on liver biopsy like APRI and FIB4, whether they are actually feasible to be used. So we set up at our hospital, which is St. Paul Hospital, Millennium Medical College, which is one of the tertiary hospitals in Ethiopia. We use the FibroScan as a gold standard. We have seen previous meta-analyses. They recommend FibroScan for Hep C patients as a gold standard. So we use the different thresholds to diagnose no fibrosis and also cirrhosis. We use 11.7 to diagnose cirrhosis and less than or equal to 7.9, no fibrosis. This is from studies in the African, Asian, and also other European countries. And we compare mainly the APRI and the FIB4 against this gold standard. Then we assess the sensitivity, specificity of the tests, different predictive values, and then we use the AUROC, which is the area under the reservoir operating curve, to the liver biopsy. The criteria used are mainly those who can't consent, adult patients. At this clinic, mainly see adult patients, so we see adult patients who are able to give consent, who have confirmed hepatitis C virus, and that are willing to be enrolled and participate. And we exclude patients who had prior treatment with DA, patients who had diagnosed with HCC or comorbid illness and terminal illness had been excluded. So majority of them were women, and the median age was 50 years. And we have seen major genotype in our country is genotype 4 and followed by genotype 1. And we have seen that the sensitivity of the APRI at a lower threshold, 0.5, was actually 75 with AUROC of 0.84. And you can see for cirrhosis, as at a lower threshold, has a sensitivity of around 75 and specificity of 95 with a ROC curve of 0.90. You can see the FIB4, also almost comparable, but it has a lower sensitivity and specificity from this study. You can see this graph showing the AUROC for A, as you see for fibrosis, significant fibrosis, and in B, we can see for cirrhosis. So the AUROC for APRI quite better than the FIB4 actually in these studies, especially for diagnosing of significant fibrosis. So this shows that APRI has a good diagnostic performance, but the cutoffs that had been used in different countries or recommendations like 2 was actually showing a lower. So we had cutoff 1 has a better sensitivity and specificity. So my conclusion is non-invasive test, especially APRI, has a good performance to detect cirrhosis at a lower threshold. So it can be used for early diagnosis and follow-up. So we recommend actually other for collaborative studies to see the APRI and to assess the different cutoff values. And I recommend, this study recommends a cutoff of 0.5 and 1 for severe fibrosis and cirrhosis respectively. So thank you for your time and attention. And this is my email address. I also would like to invite you for the next African Hepatitis Summit, which will be held in Ethiopia. And thank you so much.